Welcome back to the Deep Dive. Today we're tackling something really important, maybe a bit heavy, but essential. The sustainability of independent adult hospices.
That's right. We're talking about the places providing that critical palliative and end-of-life care across England.
It's intensely personal care, often, kind of overlooked in the big picture, but the sector's facing huge financial pressures right now.
Yeah, and our deep dive today comes from a pretty comprehensive report by the National Audit Office, the NAO. They look specifically at the financial health of these independent hospices.
So we want to get behind the headlines, understand the economics, how care itself is changing.
And why the finances of these charities are, frankly, critical for the whole health system.
Because these are independent charities, right?
Yeah.
But they're essential partners for the NHS, providing care free of charge.
Exactly. And the scale is significant. In 2023-24, the year they looked at, they cared for about 251,000 people. And that number, it's only going one way and fast. This isn't just a temporary budget issue. It's a systemic challenge. Demographics are driving it.
Okay, let's get into that then. Segment 1, rising demand and how care is delivered.
So the sheer scale of the need, it's quite something. The hard data, it shows the number of people aged 75 or older in England. It's projected to jump by 47% between now and 2044.
47%, that's huge.
It is. We're going from about 5.5 million now to potentially 8.0 million people in that age group.
So in just 2 decades, nearly half as many, again, folks likely needing complex end-of-life care planning.
Precisely. And linked to that, the total number of deaths registered each year is also set to rise, about 21% increase expected.
Okay.
From around 544,000 deaths in 2023 up to maybe 658,000 by 2044. These are, baked-in demographic shifts.
Guaranteed changes.
Yeah, they demand long-term thinking, but the places meant to handle this are, often struggling day to day.
And it's crucial to remember what these hospices offer, isn't it? It's not just like an NHS ward.
Not at all. They focus holistically on quality of life. That's what makes them different.
Things like pleasant environments, calmer spaces, complementary therapies.
Yes, and vitally, support for the family, too. Counseling, bereavement services, things that, the NHS under pressure maybe can't always prioritize but make a massive difference.
Right.
And they also do important work in training healthcare professionals and clinical research, often unsung work.
And you mentioned how care is changing, where it's delivered.
Big time. There's been a dramatic shift really reflecting what patients have wanted for decades, away from the traditional inpatient unit.
And into the community.
Exactly. Into people's homes, the numbers are stark. In 2023-24, 55% of the sector's activity was actually delivered in patients' homes, hospice-at-home teams.
55%. Compared to what in the inpatient units?
Only about 17% in the units. That's the image most people have of a hospice, the building, but most care is now outside it.
Wow.
And this matters because, while studies consistently show it's what people prefer.
People want to be at home or maybe in a hospice, right? Not a hospital.
Precisely. Hospitals are usually the least preferred place to die. In 2024, only 5% of deaths happened in a hospice inpatient unit. But providing that complex care at home,
it needs resources.
It's resource intensive. You need nurses, transport, 24/7 availability. It's a great model. Better outcomes, can even save money by avoiding hospital stays. But it needs proper, flexible funding.
Okay, so demand's rising, care is moving into the community, needing flexible resources. Let's talk money. Segment 2, the funding model. Charity versus government commissioning.
Right, this is where the instability really lies. Total income for the sector in 2023-24 was around $547 billion.
Okay.
But the key thing, the metric you have to understand, is their reliance on charity. About 2/3 of that total income
2/3
comes from charitable sources, totally separate from the state.
So that's things like their charity shops.
Yep, retail activity was about 26.1%, then donations 15.4%. And legacies, gifts, and wills are crucial. That was nearly 15%.
So the government funding is the smaller slice.
It is. About 29% of total income, roughly $420 million, and that mostly comes from the integrated care boards, the ICBs.
Okay, quick pause. ICBs. Remind us what they are again, for anyone less familiar with the NHS structure.
Sure. ICBs, integrated care boards, they're the regional NHS bodies in England, relatively new. They plan and pay for healthcare in their area. Took over from the old CCGs.
Got it. So they hold the NHS purse strings regionally and commission palliative care.
That's the idea, yes.
So the 29% government funding, how far does that actually stretch compared to the cost of delivering the care?
Ah, good question. If you take out fundraising costs, just look at service delivery spending. That government money only covered about 40% of what was needed in 2023-24.
Only 40%.
Yeah. The other 60% has to be raised through, well, charity shops, donations, legacies.
And the NAO report said the way this 40% from government is given out is messy,
Well,
inconsistent.
wildly inconsistent, yes. The fragmentation is pretty startling. You've got some hospices getting over half their income from government sources, 9 of them. But then 14 others got less than 10%. And 4 hospices. They received absolutely zero government funding. Zero.
How can it be so varied?
It often comes down to how they're funded. The big problem is the continued use of grants rather than proper service contracts.
Right, they're meant to be moving away from grants, but they're still around. What's the actual problem with a grant, strategically?
Strategically, it's a major issue. A grant is often just a lump sum, maybe based on history, without specific things the hospice has to deliver tied to it. The NAO found 26 out of 42 ICBs were still using them.
Okay.
The critical flaw. Grants don't require the hospice to report activity against that funding, so the ICB is basically funding blind.
They don't know exactly what services that public money is buying.
Exactly. They can't properly assess the volume or type of care, which makes strategic planning across the whole system, trying to balance resources, almost impossible.
So the ICB can't really use the hospice sector effectively to ease pressure on hospitals if they don't know what capacity they're actually funding.
Precisely. And then when an ICB tries to move from these old grants to proper contracts...
It causes problems.
Oh, yeah. Big disputes. Because it shines a light on those historical funding differences, it reveals maybe some hospices were funded more generously based on history, not current need. So making it fair becomes really complicated, politically difficult.
Okay, so we've got this fragmented funding, heavy reliance on charity, inconsistent commissioning, layer on top the recent inflation, wage pressures. What does that actually do to a hospice's finances?
Yeah.
Segment 3. The financial strain on the fallout.
It adds up to, well, a crisis, frankly. The financial health across the sector has deteriorated badly. In 2023-24, 64% of independent adult hospices reported a deficit.
54%. That's nearly two-thirds running at a loss.
It's the highest proportion in the last 10 years. Overall, the sector spent $78 million more than it brought in that year.
Wow.
And total spending hit a record high, $1.55 billion, driven mainly by, well, inflation, but also wage costs. Staff costs are around 70% of a hospice's budget. They had to try and keep up with NHS pay raises.
Right. During COVID, didn't a lot of charities get extra support or see donations go up? Did hospices manage to save any of that? Build up reserves?
They did, for a bit. Reserves definitely peaked around 2021-22. Back then, 88% of hospices had enough cash tucked away to cover 6 months or more of running costs.
That sounds healthy.
It was, but it didn't last. By 2023-24, that figure had dropped sharply, down to 73%.
So they're eating into their savings.
They're using their rainy day funds just to cover everyday bills, just to keep services going.
And presumably their ability to refill those reserves is weaker now, too, given the reliance on fundraising and shops.
That's the other really worrying part. The efficiency of their fundraising, the return on investment, dropped quite dramatically.
How so?
In 2023-24, for every £1 they spent on fundraising activities, they only got £1.96 back in income.
Okay.
Now, if you ignore the weird pandemic year, this is the first time that return rate fell below £2.
What does falling below £2 signify? Why is that a benchmark?
It basically means the whole charity machine is becoming less efficient. It's likely a mix of things. Maybe charity shops are less profitable. Maybe the cost of living crisis means people just can't afford to donate as much.
So the engine that provides two-thirds of their income is sputtering just when costs are highest.
Exactly. Less efficient fundraising at the exact moment operational costs are peaking. It's a perfect storm.
So the inevitable question. What are the real-world consequences? What's happening to services patients rely on?
We're already seeing cuts, serious ones planned for 2024-25. 11 hospices told the NAO they were reducing services or making staff redundant.
What kind of cuts?
Things that hit that holistic care we talked about. Reducing bereavement support, closing some of those vital hospice at-home services, cutting psychological support.
These are the things that really differentiate hospice care.
They are. And physically, in terms of capacity, the report mentioned a big drop in beds. Around 300 inpatient beds were deregistered or withdrawn end of 2024.
300 beds. How much is that national?
That's about 14% of the total inpatient hospice beds in England.
14%. Wow. Now, is that entirely bad news? If care is shifting to the community, maybe fewer inpatient beds are needed? Is it just reflecting that preference?
That's a fair point, and the NAO does acknowledge some reduction might reflect that transition. But those inpatient beds are still absolutely vital.
For complex cases.
Yes, for complex symptom management, for respite care giving families a break, or for people whose needs just become too much to handle safely at home, losing 14% of that capacity.
It puts pressure back on hospitals.
Exactly. It means the most difficult cases might end up back in hospital, the place patients least want to be, and it reduces choice.
And cutting things like bereavement support, that just leaves families to cope alone, doesn't it?
It pushes the burden entirely onto them, often with long-term consequences for their own health and well-being. It's a significant human cost.
Okay. Is there anything positive?
Yeah.
Any signs of adaptation? The report mentioned hospice collaboratives.
Yes, that is a positive development. These are groups of hospices banding together. There are about 7 well-established groups now.
How does that help?
It helps fight that fragmentation we discussed. They can approach the ICB, the funders, with a single, stronger voice. They can plan services together across a region. And importantly, they can share some of the financial risk.
So it provides a bit more stability than a single charity standing alone.
Exactly. It's a smart adaptation to a difficult environment.
Okay, let's try and sum this up then. Outro time. What does this all mean for you, the listener?
Well, it means the system providing really high-quality, specialized end-of-life care, the care most people say they want, is under enormous strain, systemic strain,
You've got this wave of demand coming from an aging population.
colliding with a vital service that we've somehow allowed to depend mostly on charity shops and bake sales. Fragmented funding.
And the results are real. That 14% loss of inpatient beds. Cuts to support services families desperately need, right when more families need them.
The core tension is relying on private charity to essentially subsidize a public necessity. And, here's the final really provocative point from the NAO report. It kind of sums up the strategic gap.
Go on.
The Department of Health and Social Care and NHS England. They currently don't actually know the total amount the NHS itself spends on palliative and end-of-life care in its own settings.
They don't know their own spending.
No. Nor do they have a clear picture of the total reliance on this independent hospice sector across the whole country.
Wow. Central government doesn't have the basic numbers on the total system cost for this essential service. That's staggering.
It is. So think about it. We know more people will need this care each year. We know high-quality palliative care is absolutely central to the really difficult ongoing debates around assisted dying. So how can government ensure everyone gets fair access, fair choices, right across England?
If they don't even have a handle on the total cost or who's providing what where.
Exactly. How do you ensure equity and make strategic decisions without that basic oversight of the whole system? It raises huge questions.
It really does. It feels like a critical piece of our national health infrastructure is being propped up by, well, the goodwill of shoppers and donors, fundraising for essential death care. A lot to mull over there. Thanks for walking us through all that today.
My pleasure. It's important stuff.
Absolutely. Catch you next time on The Deep Dive.